that we have to start it now. We have to start now. This session is an open session for question, comments. Secretariat, please check whether Professor Steiner still with us, if she wants. Some people came to me and said, hey, this morning, not very few questions. I said, don't worry. If this session there is no question or comment, I'll go one by one. So no one will be skipped. But I'll start with the first question, which comes from the presentation of our colleague from Korea, Professor Dak Sun. He mentioned, I asked him why his accreditation program worked with many countries, but not in Thailand. And his response is that we are in different regions of WHO. I replied myself quietly in mind that if the WHO is the obstacle to our collaboration, we should not have the WHO. The WHO should support us to collaborate. So we have the WHO representative to Thailand, who used to work in DPRK, very close to you, but a different country, different region. Dr. Jonas, I asked him to address this question. Very straightforward, Jonas. No politics, no diplomatic here. Please.
Thanks, Stuart. You know, I'm supposed to be diplomatic anyway. I think WHO is, in a way, the most democratic, I would say, organization in the UN system as far as member countries is concerned, because member countries decide which region they want to be. Not only that, they decide on their leadership. So that's the diplomatic aspect of it. This regional division has not always worked optimally because it also depends on the dynamics of the regional directors. It so happened it's human nature that sometimes the regions don't work well because the two systems or the two CEOs, in a sense, do not have an optimal relations. Nevertheless, the relation between the Western Pacific Regional Office and Southeast Asian Regional Office is improving greatly. And currently we have a new regional director in the Southeast Asia region. And in her commitment, she has clearly said one of her priorities would be looking into better relations among regions or WHO's image globally. There is a regular meeting between the two regional directors to see how best a smooth relation could be looked into. But in practical terms, we do work a lot together, like the Mekong network, which allows the two regions to work directly, the countries of the six Mekong countries to work directly without going through the region and the bureaucracy, is an example. And the other is the Asian Pacific Observatory is another good example where the two regions work together. So I don't see a problem on that. I think we can move ahead and see how best to work.
I met with the two regional directors last month in Hanoi. The ASEAN +3 Health Minister meeting, the two RDs were there. And they both confirmed what Jonas said. And ASEAN +3, including Korea, Japan, and China, is a very good mechanism for us to collaborate beyond the region, beyond the WHO region. And actually, 2 weeks ago, we have the 8th conference of the AAAH, Asian Action Alliance on Human Resource for Health. This now go beyond the two regions to include Eastern Mediterranean region as well. And all the three RDs are very supportive of this network. So the WHO bureaucratic structure wouldn't be the obstacle for collaboration. We have other mechanisms, which WHO also very supportive. Now the floor is open. Let me request for some ground rule. In order for everyone to have the chance to speak and share, I would like to request that everyone who want to ask questions or comments, please within 2 minutes, preferably in 1 minute, which means that please be concrete and concise so that other people can speak. And if you can limit only to one question or one viewpoint, that would be best. We have 5 presentations. You can ask questions to those 5 except Professor Steinert. Okay? So, and before you speak, please introduce yourself, just say your name and where you're from. That's enough. And if you take the floor again, please do it again 3 times, so that people, after 3 times, people will memorize and remember you, okay? And also it's to remind you that you already speak 3 times. Okay, the floor is open. Yes. When you speak, please press the button that has your face and some voice from your mouth. That is the speaker.
Yes.
My name is Kuning Kapjit. I'm from Chulalongkorn University, the past president of Southeast Asian Regional Association for Medical Education. My question is to anyone who's doing the reform, what will you manage I wouldn't say old, but it is the old style, old idea professor. They do not want to change. What will you do?
Old idea professor doesn't mean that very old by age. Even young can have old idea. But very senior, like Professor Jalat, Professor Gopjit here, they are senior, but they have new idea, okay? This is a question posed on the table. Anyone want to answer or pose new question, please go ahead. So Professor Chalerm, right? You raise your hand, no? Okay. Ask question. You don't have to answer to Professor Gopjit. Have other question you can raise now. Okay, please.
Vanisha from Mahidol University. I have a question for all speakers. Please describe the 3 most challenges for future faculty development in your country or in your institutes.
3 most. Wow. We have 2 questions now. To respond to the first question, this is the challenge for change. Professor Tarun?
I'll think of one. I guess it's very common for many people to want to teach the same way that they were taught. So we're all very conservative. We want to do things the same way. And I think even very innovative schools, when you talk to them, they say, actually, it took us a generation, 25 years to, have everyone thinking the same way. So I think while you might be ambitious and you'd have the thinkers, the leaders who really want to change things, others will be slower. And I'd say don't get discouraged by that. So accept that that's normal and just bring everyone with you. So I think, expect to have some resistance, expect to have to manage that, expect that it might take time, but you can start making changes. And changes can happen both, I think, from grassroots, from the bottom up, or from the top down.
Anyone want to add to that? This is the management of change. Add to this, please don't go to new issue, okay? Add to...
No, I just want to ask another question. Is that all right?
I'll finish with the first question and go to you. Any senior would like to, with huge experience, would like to address Professor Gopjit's question, management of change. Yes, please.
Ian Cumming from Health Education England. I think we have a saying in England about enforced change, where people are told that they have to change and then they struggle to buy into that concept of change. So what we try to do is to get people to buy into the change in the first place, so to spend much more time on explaining and exploring why change is necessary, so that people then accept that it is part of their responsibility to help take it forward. Certainly just telling people to change doesn't work because of the emotional response that people go through of sadness, anger, resentment, if you go through that enforced process. So as difficult as it may be, investing that time up front in trying to get people to understand why change is necessary would be my thoughts.
Thank you. Yes.
So for the first question, I would like to give some idea. I think that I really like, if you remember, we have the approach, the 4 quadrants in different responsibility to have reform. I think that if someone fits to quadrant 1, someone fits to quadrant 2 or 3, everyone has to take a part. And when we have a successful story, so everyone move the same direction. So I think it's easy for everyone comfortable to fill in each quadrant.
Thank you, Professor Prayun. You breached the ground rule. You didn't introduce yourself. He is the new dean, still hot in his seat, new dean of the School of Public Health, Mahidol University. Professor Gopjit's question reminds me of what Machiavelli, the father of modern political science, once taught that it is very dangerous and with high risk of failure to innovate or to try to change anything. What we are doing is try to change. So it's have high risk of failure and also dangerous. Why? Because there'll be loser and gainer. The gainer will just stand and see and watch your movement. And when you are successful, they move in to get the benefit. The loser will fight to death to kill you, to kill your innovation. So what he taught to all the princes, or all the princes in Europe in the Middle Age, that if you want to be the king, if you want to change something, you must involve the gainer and the loser. Make the loser feel that while they lose, the public gains. And make them lose as little as possible. That get them buy-in. And bring in the gainer, they have the responsibility for change. They just cannot be a free rider. This has been taught long ago. And I'm sure that it's still valid now. Now, Professor Vanisha's second question. Can you repeat it?
Hope it's the same question. The 3 most challenges for future faculty developments in your institutes or in your countries.
I would say please come with just one. You are from Institute of Gabriel, Professor Tarun, Ian, and others. And I see so many Thai leaders from the professions. Some of them are deans. If you want to choose the one most important, please. Maybe I ask from the Thai side, Professor Virapong. You can speak in Thai. There is an interpretation. One most important challenges, right? For faculty development. This is faculty development now. Professor Vanisha put this on the table. And when all of you respond finish, I'll ask her to propose one as well. She has the responsibility to propose one, not just to ask the question, but also answer. To be fair, Professor Virapong.
Yeah.
He's the Dean of the Medical Technology.
Medical Technology, yes. ขอพูดภาษาไทย โอเคส่วนสำคัญที่จะเรื่องของการทำไอ้ faculty development ส่วนใหญ่นะมันต้องเริ่มจากการบอกกล่าวส่งให้รู้ก่อนนะครับมันการส่งต่อเพื่อให้เข้าใจเพื่อ convince ให้เขาเปลี่ยนเนี่ยมันเป็นเรื่องสำคัญนะครับแล้วก็ค่อยๆจัดเวิร์กช็อปทำแผนต่อไปเพราะฉะนั้นความสำคัญอยู่ที่ communication is the most important.
Thank you. Communication is a key word. Next, please.
My name is Daruni. I come from nursing profession, sitting here on behalf of the nursing council, but I myself come from university. I think that the most challenge for future, for faculty development, is to make faculty development is a system, really a system, and the most important in the future that we haven't done much now is the evaluation of the impact of the faculty development.
Thank you. I would also like to remind you about Professor Steiner's 4 quadrant, and she said she chose 1 and 3 in parallel. I hope you remember that. Informal, group, and formal individual. That was what she chose. Any other input? Yes, the gentleman here. Yeah, please. Jan Pongsak, and then Jan Chalam.
I think the most important challenges are the vision and mission of the faculty leaders. I think this is very important. The leadership of the faculty.
So strategic and systematic management. Ajahn Chalam. The same words, okay. Ajahn Manisha, you have some good keywords now. Yes, please.
I'm Kanda Chaipinyo from the Council of Physical Therapy in Thailand. I just want to respond to this question because from my experience, I think that to faculty development, the first part that is really important to get everyone involved. If you can get everyone to involve in the process of transformation, that is the key of the successful. Otherwise, they will just ignore it. And maybe another part is to get everyone to know about the changing in education for today. Most of the staff will be stick to what they had experienced when they study, but not what is going on right now. So I think the 2 days that will be ahead from today will be very important for our staff too.
From the response so far, I got 2 important keywords. First, communication. And not just communication to inform, but communication to change. From inform to change, several steps. But key is communication. Second, strategic and systematic management. Okay, I have 2 now.
Thank you. I'd just like to
Gabriel from Hong Kong.
Yes, Gabriel Leong from the University of Hong Kong, sorry. I think, to me, the most important element is really to figure out what are the incentives, what is the incentive system to make people want to do the right thing and to be your champion change agents, whether that's because of the aspirations, whether that is because of the personal circumstances, what drives them. I think that to me is oftentimes one of the turnkeys in successful change management.
Appropriate incentives and motivation. I would add motivation. My understanding is that incentives are usually external things that push you or drag you to do something. Motivation is something internal that within yourself you have drive to do it. Yeah.
Pisek Lumpikanont from Faculty of Medicine, Khon University. I would like to emphasize the first issue raised by Professor Kunying Kopjit. To me, the first challenging is to move faculty members from their comfort zone, in which they have been working for years. And we have been discussing this, that there are many strategies to do that. I also would like to support Great Bill that in terms of the three main responsibilities of faculty member, namely taking care of patients, and secondly, the research work. I think those who devote themselves for education for the student receive the least incentive and motivation to do so. So I think we have to develop appropriate incentive and promotion system to reward these faculty members who devote themselves to teaching students.
Thank you. Anyone want to add to that?
Thank you. Jonas from WHO. I'm not an educator, but from looking at the change, I see another factor which is important. This is timing. Persistent, but also patience. In terms of, if you rush it, it can break. If you delay it, you can lose the motive. So time is also of importance. That's my comment.
Thank you. Kenji?
Just quickly, I think, reform cannot be done on just one day. So as Lincoln articulated, as our friend from WHO mentioned, that the patience is important, but also partnership, networking. You don't have to work alone within the university. You can work together with people outside, particularly ministry or industry, or even sometimes politicians. So partnership will be quite, in addition to communication, partnership will be quite important.
Like what we are doing today, like what Dr. Professor Vanisha and Pisek, supported by Lincoln, bring us together. And we'll have time to exchange our view, building network, sharing our experience. I think we have enough for, okay, one last.
Okay. I think that's the most important thing that we have to, why do we have to reform? That's the most important. We have to communicate them and inspire them too, based on fact and information. What the situation right now, if you want to be the excellent, what you have to reform or not. And you have to inspire them to do the same thing if you want to be excellent. So we have to go to the same direction and accept it. I think that's most important. And participation and communication.
Thank you. Yes, please.
My name is Li Pingduan from the Peking University Health Science Center. I just want to add one point is how about the evaluation system for our faculty? Just for a professor, it's based on research or both research and teaching, or even in the hospital, their clinical work. Thank you.
Thank you. I would add that into the keyword systematic management, which should include evaluation into it, like our colleague Professor Tharun did for his rural medical education program. Systematic evaluation and feed into reform activities. So I would summarize communication for change, not just for information. systematic and strategic management, including evaluation, appropriate incentive and motivations, partnership and networking. I think that is enough for you, Professor Vanisha, but yourself should give one, please. Not the same as the four.
Vanisha from Maidun University. It's third time now. The most challenging in our university, I think, to formulate the common goal to encourage all faculty members, not only for policy makers. It is very important. It includes to generate the purpose, the process, and also the evaluation as well.
So I would add that to systematic and strategic management, which include involvement, participatory process to develop vision, mission, strategies, and implement the strategy and evaluate the strategy under good leadership. It's easy to say, but when you do it, it's quite challenging. May I go to next question? I see a hand of our colleague at the back there.
My question is about the leadership.
You have to speak the second time.
Yes. May I introduce myself again? I think not. My name is Kanda, and I'm a physical therapist. So my question is about the faculty development program, because we, since this morning, we're talking about the interprofessional collaboration. Is there any example, rather than just, I heard from one of the speakers about the nurse and the medical doctor working together for 2 years to follow up the patient. But how about other health professions that can be involved? If you can give us some idea of the example that you have done, maybe because I'm a physiotherapist, I'm especially interested in that. Thank you.
Yes, thank you. Gabriel Leung from Hong Kong. That's the example I gave. Unfortunately, our faculty comprises Western medical doctors, Chinese medicine doctors, pharmacists, and nurses. But we don't have a program in the rehabilitation sciences. So what we do is, yes, we have now doctors and nursing students working together, and we are looking to expand that and extend that to the other two professions that we teach. So that's pharmacists and Chinese medicine doctors. But we don't really have that opportunity, at least under the same roof with physiotherapists and occupational therapists.
Ian?
Ian Cumming, Health Education England. I think you raise a really interesting question. I can give 2 or 3 examples of where in the UK we are trying to build the multi-professional working. The first is an example at a university where every year they run a major incident simulation on the university. So they have a pretend gas explosion or a train crash or something like that. And the doctors and the nurses and the physiotherapists and the pharmacists and the paramedics are all supposed to play their role in the simulation, but they also bring in people from media studies to act as reporters. They bring in people to film it. So it brings in the whole university way outside just health, and it's a major program that runs over 3 or 4 weeks with the actual simulation to start with, and then everybody takes it back into their own professional environments and looks at what they've learned from it. And it's something that the students on the university look forward to every year, because as well as being important learning, they have fun while they're doing it. The other area that we haven't started yet, but we're looking at starting in my own organisation within the next year or so, is how we start blurring some of the boundaries of traditional professions. So we believe that there is a need for nurse therapists, people who are trained in nursing but also trained in physiotherapy. Ultimately, we would like to be able to offer that as an undergraduate course, but to start with, we're going to offer nurses the opportunity to do a master's in physiotherapy and physiotherapists the opportunity to do a master's in nursing, so we can start to blend the professions together so they can learn the best from both areas. In the postgraduate arena, areas such as trauma teams, we do a lot of work in actually training in a multi-professional environment. We bring in a whole team together to actually look at the response to a major trauma call, for example. We don't just train in professional silos. So it's a direction of travel that we need to go in further and further. And we have a saying that we want to move away from simply putting people in a lecture theatre, because that is not multi-professional interprofessional learning, into people actually understanding how their different roles contribute to the care of a patient when they come and work together.
Thank you, Ian. Anyone want to add to the response? Yes, please. Introduce yourself the third time.
Okay. I'm Prayun, Dean of Faculty of Public Health at University, also the Chairman of Public Health Institutional Council of Thailand. I will give you some example for the faculty. Almost every year we have a comprehensive field training. And we have almost a group of 300 students go to the village, different villages, a group of the health team. Maybe the first year of medical doctor, also the bachelor, master, also the DRPS in different areas like pharmacists, engineer, and mental health side, nutritionists, or whatsoever. We come as a health team and spend about 6 weeks in the village. The first 3 weeks identify what kind of the problem, what is the web of causation, and set a priority. And then the second and the third week, we're going to set the implementation and evaluation. And this first, we do it about 20 or 30 years now. We call it IPE, Interprofessional Education. And so we learn a lot from that one. We can learn the leadership, can learn the communication, learn the teamwork, and system thinking, learn by learning by doing, not just by the classroom.
Do we have any example from Japan, Korea? While you are thinking, I want to share with you one story. There was a special program for the disabled, dental care for the disabled in the northern province of Thailand, in Chiang Mai. The dentists who work in the rural hospital moved into the village to provide dental care to the disabled at home because very difficult for them to come, particularly the mentally handicapped. Usually they never receive dental care at all. But when the dentists start their services, they found that, hey, this patient, this disabled, needs more than dental care. They need medical care, nursing care, physical therapist. So they start to bring in these people which are available at the rural hospital to move in, to work together. Of course, that is not interprofessional education in the institute, but this story may give us an example that interprofessional learning may be less challenging at the community level, where professional boundary is not very strong. But in the educational institute, the professional boundary may be stronger. So the answer may be education or learning at the community level. This is not the single answer, but one example as you request, for example. Professor Tarun?
Yes, just to comment on a couple of those things about professional boundaries and how things happen in the community. A lot of the innovation comes from the coalface. A lot of the innovation in Australia has come from rural settings where people just had to find a way to make it work. And the things I'm thinking about here were, innovative solutions to problems. One is the observation in many rural towns that ambulance officers, ambulance drivers, were only working 1 or 2 hours a week, but they're highly trained professionals. So just as Ian said, they then retrained as therapists. They could do some physiotherapy and other things. So you had the resource in the town, highly trained, but not working at the full scope of practice. So you can use that resource as locally based to do things in a different way and offer physiotherapy or other services that were otherwise not available in the small town. Secondly, the concept of the physician assistant's been in the US for a long time, but we're seeing people now where we have visiting podiatrists or physiotherapists to a small town, then train a local person to be the podiatry assistant. So they have a more limited scope of practice, but the skill, that resource is in the town forever. So they know what their scope of practice is, they can refer back to the expert, and that, is delivering the service locally, so it's close to the community, and it flies in the face of professional silos. But I think the unifying theme here is, let's focus on the needs of patients, and let's focus on the needs of the community. If you get that right, then everything else flows from that.
Thank you. Korea, Japan.
In Korea, as Mr. Chairman pointed out, that at the community level, some medical schools have a very small program, but culturally, the boundary between the profession is so thick. So that's our weakness. And it's also hierarchical society, so it's not easy. People understand there's a perceived need and perceived advantages, but moving towards the IPA is a challenging. I'm not from Japan, but last year I was invited to attend Gunma Medical School in Japan. Had an official WHO designated center for IPE. So Japan might have more experiences in this field, but not for us.
Kenji.
When you talk about interprofessional work, you need to talk to the medical association and nursing association, and they are just blocking that. So my proposal, similar to colleague from James Cook University, I think it's important for the younger student to be exposed to different environment, community or different entity. I like the idea of pairing nursing and medical student work together at Hong Kong University. But to me, it's a little bit too late because there seems to be hierarchy. You are a doctor to be, and you are a nurse to be. But I think from the beginning, for example, is there any university or medical school or nursing school which provide the core curriculum for medical students, nursing students, or pharmacy students together just for 1 year? And if nursing student exceeds the medical student, she could go into the medical school from the second year, for example. That kind of environment would be quite interesting.
Mahidol University used to do that for a few years. The result is that students chose to other medical school rather than coming here because their future was not certain. Their future was not certain. They have to study together with all other health science students, and then after 2 years, they'll be selected whether they'll go to medical school or not. So the best brain student move out from coming to Mahidol University and to other university instead. But that is a challenge. That is just a challenge.
My second time, Pisek Lumpikanon from Konkan University. I have 2 examples of what we have been doing in terms of interprofessional education. One at the community level, in which 30 years ago we initiated the community medicine training program during the summer period, whereby all the students from all faculties in health science, medicine, nursing, medical technology, pharmacy, dentistry, and later on veterinary medicine work together in a selected village as a team to identify priority health problem in that area, develop intervention to solve that problem and evaluate. and the students work under the supervision of faculty members in doing that field work, and they experience many aspects of working together or teamwork. The second experience that we have inside our hospital is what we call quality ward lao, conducted by internal medicine department, both the doctor and nursing. And we also invite students from faculty of pharmacy to round the patient together. What are the role of the doctor, what are the role of nurse, and what are the role of clinical pharmacy, working together on each individual patient.
Thank you. I think we have enough for that, but I don't want to miss the African example. But before we go to Patrick, in Thailand, we have a national committee to move the strategic plan. This national committee is interprofessional and also include all partners, including WHO, and even local government, the patient's representative. In organizing national conference, which will be the next 2 days for the next 5 years, interprofessional education and learning will be one of the themes for the 5 years. I think the third year, right? Next year will be interprofessional. We are in the session of institutional reform, but I'm sure that Professor Lincoln and Julio, who start this commission report, lead this commission report and global movement, would be very happy that we do not think, although we are in one issue, in one theme, we also address the other theme. Patrick.
This one. Thank you. I'm Patrick Kadama from the African Platform for Human Resources and Health. Just one comment about the approach in Africa, East and Western Africa, has been through the health professional councils. Following 20 years ago, a fragmentation into very many statutory councils for health professionals, there has lately been a move to try and put together what are called Joint Health Professionals Authority. These are bringing together the regulators of health professionals on round tables to agree on commonalities and to put together joint teams that can be peer-reviewed, that can be accredited on a team basis and task basis. The process is still very early on, but the colleges of the joint colleges of health professionals in East, Central and Southern Africa and that in Western Africa are now at the stage of being approved by the health ministers in these two regional economic communities.
Thank you. I think we have maybe 9-10 minutes left before lunch. We can address one or two issues, short one. Any hands? Okay, please. Generation.
Good morning, I'm Piya Hanvarongchai from Chulalongkorn University and also CMB. I have a question to Professor Gabriel Leung and Professor Sengupta. I saw from your presentation that you have quite an interesting way of reforming from teacher-based to learner-based to be a course that's not specific to discipline. And I would guess that this would involve probably some change in the institutional structure or maybe some form of how you arrange faculty and others to be able to deliver those kind of things. May I ask if in Hong Kong, did you do anything to stimulate this change or to facilitate this change? And in Australia, I heard that in James Cook, last night I had a chance to talk to you, that you don't do department-based in the medical school anymore. It's something that's different. People are more in a group, so I would like to hear more from you about how do you organize your faculties in order to be more learners-oriented. Thank you.
Okay.
Thank you, Pierre. So what we do is a lot of these have external causes or external origins in terms of the different types of reform processes we've been involved in. So let me deal with the sort of slightly easier and more obvious one, that is postgraduate training and education. So in '93, I told you that we established our own statutory academy, which is consisting of 15 different specialty colleges training 64 different specialties and subspecialties. Now, why 1993? There's nothing very special about 93 except to say that it's before 97. And I think it's fairly obvious why. As I told you, to this day, our specialist exams are still reciprocally recognized and linked to the Royal Colleges either in the UK or Australia. And so what we needed to do was to establish a local legal framework to deal with specialist accreditation before the repatriation in '97. So that's why there was that impetus that never got realized for half a century until essentially our macro political situation changed or was about to change in '97. Because the need for specialist accreditation body was there since '68. So that's the reason for that. And then since then, we have done obviously now a lot of reform processes to push that forward to such an extent that we're now really proactively engaging our mainland counterparts, which are obviously many, many times bigger than we are, but we are now contributing to the process of having a national-based specialist accreditation and training system. So that's our postgraduate bit. And our undergraduate bit, we changed our curriculum back in '97, so almost 20 years ago now. And that's mostly because we saw that everybody else in the world seems to be engaged in updating and making sure that their curricula are refreshed. So that's why we sort of said to ourselves, well, is there something that we could do or should do to make sure that we remain relevant, as well as that we lead, at least in the region, and if not, directly competitive with the best medical schools around the world. And so that's really sort of this renaissance and reawakening in the early 90s that drove us to change in the 90s. And then ever since, we have had external statutory accreditation exercises. So Dr. Daksang told you about the Korean experience, that there is this accreditation exercise that's begun in the last decade in Korea. Well, we started with that almost 20 years ago in Hong Kong, and in fact, I just finished our 5-yearly accreditation a few months ago. We just recently got the report. And in fact, we're still very much linked into the rest of the world, and because of the way our system was derived from the UK, every time we actually bring back the chairman of the General Medical Council of the UK as part of that accreditation team. As well as we actually brought in this time somebody from Australia as well to help us with our accreditation. So that's really what's been keeping up the momentum for change. And then last but not least, the reason we changed from a 5 to a 6-year curriculum is because of the macro change in our educational system, that we have changed to add 1 more year to the university or college education experience, much like the rest of mainland China and in America.
Professor Tarun?
So if I could comment, I guess from the medical school and our medical curriculum, we had a new curriculum as a new medical school. It is said that it's easier to win a war than change by 1 hour a medical curriculum. So changing existing curriculum is difficult. Having a brand new thing to start off with was really much, much easier. You could look at the evidence, and I guess our theme was start with the end in mind. What do we want the product to look like? We had a sort of group of like-minded people who had the same vision, so you designed it around that. And so we deliberately designed things around themes. Rural was a theme, Indigenous health was a theme, social accountability and so on, but without strong departmental structures. So what became important was the student's experience and the end product, not the doctor or the discipline or the profession or the silo. So that was important. In terms of the whole rural thing in Australia has become mainstream now, and again there was a vision, and I think the thing that made a difference there was collecting evidence. So there were people prepared to be critical, but once you've got the evidence in terms of quality, student experience, the students are enthusiastic and so on. So many of our rural sites are oversubscribed across Australia. So I think the unifying themes there were really to collect evidence for whatever it is, to have a vision, and to have some critical friends. So, for example, it was very important to us in the early days of the program. The Australian Medical Council came to accredit us. We had a bit of a say in who was on the team, and having sympathetic, innovative, creative people there were very helpful. So, and it was good to have them being critical, but they were also critical friends. So I think having that sort of external scrutiny, exposing yourself, but being clear as to where you were going and what the end product looked like, they were the sort of themes.
Thank you. I saw this, one page flow chart. I understand that this is from Professor Virapong, right? Medical Technologies Education Reform for the 21st Century. Can you, in 1 or 2 minutes, explain to us? I think it's very interesting.
Yeah. Actually, the reform of the medical technology education has been done since 2000. Okay, by that time we divide that the world is changing. So then we move into readjust our curriculum. Okay, into competency-based learning. Okay, and the more important thing is like as a medtech, long before we working just with the sick patient, with the sick people to testing the blood. But we are aware that by knowing the molecular inside the blood testing, it will be very useful to use a parameter of molecular inside the body as a warning system for the health promotion. That's why we go into community. Then by that time we start the community-based learning. Okay, and by that time then we train our staff, and then we begin the new curriculum at 2002. And this has been already more than 10 years. And we also building up extra curriculum activity of the student by since Mahidol University is a research university, then we add on more critical thinking of the undergraduate student by together with the graduate student by using the researching system to help them for the critical thinking, and also multidisciplinary exposure in many branches of science.
Thank you. You have also interprofessional education here.
Our interprofessional profession, we had a group into the community. We use the community as a living laboratory, and we have also the medtech students, some of the nursing, some of the doctoral staff, and also with the social science, with people from environmental science also included in the group.
I think we are in the lunch time now. I would like to conclude this session. We have very productive and very interactive session. Inputs from 5 country presentation, country experience are very valuable for us. I'm sure that we'll have more. We have many more. Even in the country, we have many more than just one case or 2 cases of innovations. We wish that we'll share all this information over and over and over again. Professor Pisek and Vanisha started this international one-day conference before the national conference. This is the first time. I hope that it will evolve into maybe Asian interprofessional education conference in the future. It is possible if we really want to move, because there are huge experience among all countries to share and to evolve together. Don't forget your evaluation form. Please tell us information on the lunch. Piya, okay. You want to give some? Oh, okay, Piya will do that. I hand over the floor to the secretariat, Dr. Piya. For those who don't know him, he used to work in rural hospital for some years before joining the fellowship program in the Ministry of Health, and then we sent him to work at the World Health Organization headquarters for 2 years, and then to Harvard for his PhD. And now he is a lecturer at the School of Medicine of Chulalongkorn University, teaching health policy and health system. Yeah, please.
Thank you very much, Dr. Suvit Vibonphornprasert, for the moderatorship of this session. May I invite our international resource person, Professor Andokson, Professor Kenji Shibuya, Professor Gabriel Liang, and Professor Tarun Sengupta to receive a small token of appreciation from Professor Vichan Panich. Yes, to the... Okay. Professor Anduksen, please. Professor Kenji Shibuya. Professor Gabriel Liang. Yes. And Professor Tarun Sengupta, please. Thank you, Professor Vichan Panish, for the event. The lunch will be at the room next door, Patuma 2, and we will come back here in 1 hour time. So right now it's 12:05, and we'll be back at 1:05. So please come back to this room. Thank you.